I will be speaking about the mitral valve prolapse, the diagnosis, which can be basic for some of you, of course, and the added value of 3D echocardiography. Mitral valve, to start speaking, is not about the leaflets. Mitral valve is an apparatus. So these leaflets, mitral annulus, chordae, papillary muscles, and even the left ventricular wall segments carrying the papillary muscles are part of the mitral valve apparatus. Because simply, and you will agree with me, that if everything of the mitral valve is normal, but the LV is weak and dilated, the patient will have mitral regurgitation, right? So LV is considered a part of the mitral valve apparatus, and proper function of the mitral valve needs harmony and integration between all of these components of the mitral valve. Whenever we say mitral valve prolapse, we usually think about mitral repair, not replacement. This is the standard of care in specialized centers. So first of all, we need to identify whether it is prolapse or not. Second thing, which scallop and how many scallops. It is not accepted now with this advancement in the imaging to say this patient has mitral valve prolapse and that's it. We have to specify which leaflet, which scallop. And for the repair feasibility, we need to identify that the leaflet length, the scallop length, the affected scallop length, and the condition of the cords. Are they ruptured? Are they like lousy, just elongated cords, or they intact? And the annular dimensions, is there any risk of SAM and mitral regurgitation severity? The diagnosis of mitral valve prolapse. Previously, in the very old days, when they realized that some patients have some mitral valve tissue beyond the mitral annulus, and they said they had no cut-offs or fine-tuned definition for the mitral valve prolapse. So the first definition was any part of the mitral valve at any view that is beyond the annulus is prolapse. And depending on that definition, 17% of the normal population were identified with mitral valve prolapse, like an epidemic, more than corona. So 17% of us, based on that old definition, had mitral valve prolapse. And then they realized later on that the mitral annulus is not a planar structure, but rather a saddle-shaped one. The anteroposterior points of the annulus is higher than the intercommissural points, like a saddle above the horse. Based on that annular shape, they said, okay, that means in order to diagnose the prolapse, we have to cut the higher points of the annulus at one view, which is the anteroposterior view, the long axis view, and then anything beyond this will be prolapse, which is okay, but only for patient that is having A2 or P2 prolapse, because the long axis view that cuts the anteroposterior points of the annulus that are high is the long axis view, whether parasternal long axis or apical long axis or mid-esophageal long axis, anything which is long axis, cutting the anteroposterior points and cutting only the A2 scallop and P2 scallop of the mitral valve. So patient like this, the same one that we did analysis for, P2 prolapse will appear like that. That's fine. If I cut the long axis view, which is like this, I will be able to diagnose the prolapse, which is good. But what about patient like this? This patient, anterior leaflet is okay. This is the surgical view again. Aortic valve 12 o'clock position, looking from the left atrium. This is lateral, appendage is here, interatrial septum. So counting from the lateral to the medial, A1, A2, A3, P1, P2, P3. So this patient has a bit of lateral scallop prolapse. So you can say a combination of like B1 and B2. Sticking to the anteroposterior view, which is the long axis, will let you miss the prolapse at B1. And you may falsely diagnose this patient has prolapse in B2, which is not the case. What is the problem of like misleading the surgeon? When the surgeon opens the heart is empty, stands still, no blood, there is no contraction. So if the tissues are not myxomatous or buckled, the surgeon might not notice the real prolapse. They may think, okay, the echo showed P2 prolapse, I have to work in B2. Unless the tissues are excessively redundant and myxomatous. Otherwise, he will be misled. The good thing about the 3D echo that it shows the surgeon where is the prolapse in real beating heart, which is a very good opportunity. Once he opens the heart, it is still, no contraction. And then, currently, with the known shape of the mitral annulus and known shape of the complexity of the mitral valve prolapse that can happen in medial scallops, lateral scallops, they said, okay, if we stick to the tip of the mitral valve, not any part of the leaflet, just the tip. If the tip is above the annulus, is beyond the annulus towards the left atrium, this is prolapse, regardless of the view. So apical 4, apical 3, apical 2, any view that shows you the tip, not the body, of the mitral valve above the annulus, this is prolapse, regardless the view. And they came to differentiate between two different entities, leaflet billowing and leaflet prolapse. Billowing, if the tips are still lower than the annulus, but the body is above the annulus. Above, I mean towards the left atrium, okay? But if the tip is above the annulus, this is prolapse, but still pointing towards the left ventricle, okay? So if this is the annulus, that one, and these are the leaflets in a 4-chamber view, transthoracic. Left atrium is down, left ventricle is up. So this is normal, right? And if I did like this is what? Billowing. So the body is down, but the tips are still higher up. This one, prolapse. This one, fillate, okay? I think most of you can't do this. Right? And whenever I do this, I get a very famous question. They ask me, do you have Marfan syndrome? Yeah. I was doing this in Euro Echo, and then some of them told me, you need to check your aorta. Okay. So this is what I did, actually, what I've just shown you. From the transthoracic perspective, that was the office. أنا كنت قاعد في بذاكر كده رايق لما كنت شغال في إنجلترا فده ceiling wall interface. So this is normal. Some tenting maybe, but this is the billowing, prolapse, and this is the flay. They related all the complications and the risks, the high risk of the mitral degenerative disease to the real prolapse, not the billowing. That's why it is not good to label the patient as having mitral valve prolapse if he doesn't have mitral valve prolapse, because mitral valve prolapse per se, if real, that carries a risk, even sudden cardiac death in some patients. So it is very important to label the right patient as having prolapse. This is not a good thing to distribute, because it's something like rheumatic heart disease. That's everybody's like diagnosed with rheumatic heart disease with taking long-acting penicillin. Mitral valve prolapse has a very common, very common mistakenly diagnosed in everywhere. Mitral valve prolapse, mitral valve prolapse. Okay, what if you have a patient with TEE? Patient like this is having mitral valve prolapse of the posterior leaflet, but then the question comes, which scallop is which? Okay? Proposed protocol, if you don't have 3D and you have only a 2D probe, you can do something called long axis sweep. So a patient like this with severe mitral regurgitation with prolapse, we need to tell the surgeon or the interventionist which scallop is which. Start by the long axis view, okay? This is the aorta mitral valve appendage from the TEE perspective, okay? The long axis view cuts like this. This is the 135 view, from 120 to 140. So cuts the aortic valve, right coronary cusp, which is here. This is TEE. Anything back is posterior, anything forward is anterior, okay? Away from the probe is anterior. So right coronary cusp, and then this is the commissure between the left and none, and then the anterior leaflet, A2, in the middle, and then P2. Agree with me? If you stick to this, keep the angle as it is, and you put the probe like this, and then tilt the probe to the right of the patient. Just rotate the probe to the right of the patient. You will cut like this, right? So you will cut A3 and B3. Complete the sweep, you will cut the interatrial septum, which is here. You will get something like bicable view. And then back, A2, B2. And then lateral, left of the patient, one and one, and then the left atrial appendage. Let's do this. So severe MR coming from the septum. And then 2, 2, and then you carry on. 1, 1, and then you carry on. You will get the left atrial appendage at the end. This is called long axis sweep. You start by the long axis, and then you don't do anything unless you just turn the probe to the right and left. Don't play with the angle. The angle is the same, 134. Everything is the same. But start by the straight long axis view, and then sweep from side to side. But to know where you come from, you have to go to one extremity first, whether the septum, and come back, so the first scallops will be 3 and 3. Or the appendage, and come back, so the first scallops will be 1 and 1. Okay, long axis sweep. If you have a 3D probe that can do X-plane, in that case, don't start by the long axis. Start by the commissural view. By commissural view. When we said the long axis cuts like this, the commissural view cuts like that. Okay? A very complicated view. Appendage first, and then P1, A2, P3. I call it EBAB, 1, 2, 3. A, appendage, B, A, B, 1, 2, 3. Appendage, B, A, B, 1, 2, 3. And in that case, you apply the X-plane. Start by the commissure. Put the X-plane. If you put the X-plane in the middle, A2, it will give you A2, B2. If you put it at B1, A1, P1. B3, A3, B3. By the way, you can do the same with transthoracic. So if you have an X-plane probe like what we had in the room, you start by the short axis view of the mitral valve, short axis. And then you put the X-plane. If you put it right in the middle, it will give you long axis view, 2 and 2. If you put it in the lateral, 1 and 1, medial, 3 and 3. Do the same. So for example, this patient had a prolapse in one of the leaflets. This is the commissural view. I'm putting now the X-plane on P1. So I see A1 and P1 with and without color. Coming medially to A2, I can see A2, B2, B3, A3, and B3. X-plane, okay? If you are using 3D, no need for this mental reconstruction because you can see everything without any imagination. This is a 6-beat acquisition. Surgical view, you can see the prolapse flail even. You can see the ruptured chordae. Can you see that? You can even count the chordae, the ruptured chordae. And you can see very good delineation of the flail scallop from P1 to B2. With this volume, you can put it in the MPR and do something like what we did by the X-plane. So you put the 3D volume and you cut it by the MPR, and you do the same. Start by the commissural, put your lid line in the middle, you'll get long axis at A2, B2, and then go for P1, P1 and A1, 3, 3 and 3. So you can do this offline by the MPR. Or even more, the quantification by the MVN, mitral valve navigation, by the QLab, or the one we have just done in the room, the 4D MV analysis, which is much easier. ده بقى بيدينا ارقام كتير بقى. Quantification by the annulus diameter, the prolapsed volume, even if there is malcoaptation gap, will give you the area of this malcoaptation gap. Another example, this patient had a bit of complex prolapse. See that the main problem was at the lateral commissure. So putting the X-plane in the middle, A2, so A2 and B2, they have prolapse. So the affected commissure here was the lateral commissure, as you can see. This is severely prolapsed. 3 and 3 were not so much affected, but there is at least billowing. 3D showed a very complex anatomy. Anterior leaflet, A1, A2, A3, P1, P2, B3, and there was like something like a commissural scallop. Scallop that does not belong to the anterior or the posterior, just like this, and does not help coaptation with the anterior or the posterior. It's like accessory scallop, commissure scallop sitting in the commissure. There is no one like it in the medial one, just at the lateral commissure alone. Commissure scallop. This is a narrow sector acquisition by Life 3D. You can see this problem here. See the malcoaptation between the anterior and posterior and this commissure scallop. For sure you can do the 3D vena contracta area like what we did here. And by the quantification, what the red color is what is above the annulus. So these softwares can give you colors to tell you this segment is above the annulus, even without looking at it. Anything that is in red is above the annulus. That's prolapsing or billowing. If the red color is reaching the tip, this is prolapse. If it is only in the basis, this is billowing, and so on. So it makes things easy. SAM risk. What is SAM risk? If you have a patient with mitral valve prolapse and you are sending the patient for mitral repair. You need to identify or tell the surgeon that this patient has a SAM risk. SAM, systolic anterior motion with LVOT obstruction.
1 minute.
1 minute. Okay, I'm about to finish. If the septum is very thick or the posterior lift is very long, I will not go in numbers, so like 15, 25, this is 15. If the aortomitral angle is small, these patients having high risk for SAM after surgery. In that case, they need to either to do myectomy or to shorten the posterior leaflet to get this, the coaptation line from the interventricular septum. The last thing, but not the least, is the mitral regurgitation assessment. All these patients were assumed to be having severe mitral regurgitation, but this is not the case in many patients. See this example. If you get this water tab and you open the tab and you put some cups below this tab with a continuous flow, if you put the first cup for 1 second and then remove it, 2 seconds, 3 seconds, the longer duration, the more volume it will accumulate. Agree with me? The same for mitral regurgitation. If the regurgitant orifice is not open during the whole systole, the MR volume will be less than if it is open during the whole systole, right? That's why in patients with mitral valve prolapse, see, in some frames you will see the color very important, like very significant. Agree with me? So if I freeze, see, severe MR, everybody will say severe. And any method that is dependent on a single frame, it will tell you this is severe. Vena contracta will tell you severe. The radius, ARO, it will tell you severe. But this is systolic frame, but there is no mitral regurgitation as well. See, by the ECG, in systolic. So late systolic regurgitation only. The water tab is not open during the whole systole, only half of systole. This has to reduce the quantification of mitral regurgitation. This is not me saying that, this is a guideline. They are saying failure to appreciate the duration of MR will let you overestimate the mitral regurgitation in patients with prolapse, especially when the mitral regurgitation occurs late. So what is the solution? How to calculate this? By tracing the VTI. ARO might be significant, but the mitral regurgitation volume will be less. So in that case, calculate the VTI to get the mitral regurgitation volume, not the ARO alone. Okay? So this is what's recommended by the guidelines. So take home messages. Do not forget my hand. Sticking to the anteroposterior view, the long axis will let you miss prolapse في الميديال واللاترال. خلينا على الديفينيشن الجديد. التب هي اللي بتبقى فوق الانولس مش من الليفلت نفسها. The tip has to be above the annulus at any view, which is like enough for you to diagnose prolapse. 3D has a lot of added values in determining the location and extension of the prolapse. With duration of mitral regurgitation is very important. Thank you so much.